I hope your impression of me is not formed by my topics this year of hospice rules and regs and now renal disease. I know. So if you haven't met me yet, hopefully at the conference next,
I think I'm going to
get together. Yeah. And no, I'm not as dry, pun intended, as my presentations are. So bear with me. I have nothing to disclose this morning. Hopefully, by the end of the presentation, we will have achieved a couple of things and learned how to evaluate and manage symptoms associated with end-stage renal disease, understand prognostic factors associated with chronic kidney disease and end-stage renal, navigate goals of care conversations, including we'll have a little emphasis on dialysis specifically, and then maybe talk about a couple of medication management tactics for those who are receiving dialysis.
But if you want to hit that blue OK button, that'll make that
Yep,
harder.
we'll get that off from there. So why does this matter? For those of you who are maybe not gifted with the skill of interpreting statistics, I thought I would give us a few just basic reminders because I had to look them up. So I thought I'd share with you the difference between incidence and prevalence. So incidence looks at the number of new cases out of the at-risk population. So it's a measure of speed or rate of new cases occurring versus prevalence takes the existing cases out of the total population and more is a measure of total disease burden. So you can see over the last couple of decades, both incidence and prevalence are pretty rapidly or pretty significantly increasing over time. And this is something I just did a couple days ago. So I thought, oh, I wonder if people go out to Google and do a quick search, what will they find? Because often when I'm consulting with patients in the office, this is a question they want answered, whether it's about kidney disease or something else, but who is palliative care and how can they help me? And the first thing that pops up is from the National Kidney Foundation, right there, main part of their website. So I thought that was pretty neat that the National Kidney Foundation is recommending and talking about palliative care in chronic kidney disease. This is an article that I hope to pretty thoroughly cover, but if you want a reference for down the road, I think this is kind of like an everything you need to know kind of article. 10 tips nephrologists wish the palliative care team knew about caring for patients with kidney disease. Not super recent, but isn't super old either. I think it's
2018.
2018, yeah. Tip number 1, care for patients with chronic kidney disease and end-stage renal disease benefits from multidisciplinary input from nephrology, primary care, and palliative care. This one made me chuckle because I thought, oh, if there was a tips palliative care wish nephrologist, then we would include this. Yeah, exactly. This is important because it's pretty rare for somebody to have chronic kidney disease without any other comorbid conditions. It occurs with in about a third of patients with end-stage renal, they have 4 or more comorbidities, including most commonly cardiovascular disease, cerebrovascular disease, diabetes, and even cancers in the top associations there. There have been actually a handful of pretty good studies that have asked nephrologists and nephrologists in training about their comfort with addressing some of the palliative care related topics with their patients. And they have really said over and over again through those surveys that discussing, for example, dialysis as a life prolonging versus not life saving modality, they're really uncomfortable with that. And less than half of neurologists report feeling prepared to address end of life care. So I think that's where the assistance from our primary care friends and then palliative care specialists really is important. And then we know, I would say this is similar to those that I see in oncology, where their oncologist office becomes kind of their medical home during that time in their care. And the same is really ends up being true for those who are receiving dialysis. Their nephrologist kind of becomes their medical home. And the nephrologists are saying, we'd like some help with that. Tip number 2, our nephrologist colleague said serum creatinine and estimating equations are used to provide approximate values of GFR, which is a really black and white statement from our colleagues. I have heard quite a bit of debate over the years of, is a declining GFR, is that pathology, or is that really just normal aging? And my non-nephrology brain says, I think that's just normal aging. But we do know, regardless, a reduction in GFR is associated with decreased physical function, increased frailty, and reduced cognitive function. And that is all been shown to be true, starting with even chronic kidney disease stage 3.
And aging.
Right, which is aging, exactly.
Aging.
And kind of like the statistics, I had to go back and remind myself about what is the difference between GFR and creatinine clearance, and when do we use each of those and what for. So kind of the who, what, when, where, and why. GFR is really used for staging of chronic kidney disease. That's your stage 1 through 5. And creatinine clearance is more what we should be using for drug dosing. Although I know oftentimes when I am looking up a medication in Hippocrates, for example, it does give a reference based on GFR. And I think that's just because that's what's reported is GFR, and creatinine clearance often takes our own calculation. It's also kind of interesting because creatinine clearance is said to be what, from our pharmacist friends, what should be used for drug dosing, but the National Kidney Foundation doesn't recommend using it for clinical use. Yeah. I am not sponsored by MD Calc, but maybe should be because I use MD Calc often when calculating GFR or creatinine clearance. So it's a good tool to either have bookmarked or handy for reference on your device, because you can plug in a couple of numbers and get real-time, up-to-date calculation. And then I always use the CGF for creatinine clearance calculation. It has evidence to show that we should be using it, especially in elderly patients 75 and older. It's better than GFR when looking at med dosing in those who have extremes of muscle mass on both ends. And then would be a better tool for people taking medications that are largely renally excreted or have a narrow therapeutic index, which is a lot of medications that we use. All right, I have to lighten it up a little bit. So what better to use than a cheesy dad joke, or mom joke? What do nephrologists say to, we'll call non-compliant patients? One,
Spilling the beans.
You're in trouble.
you're in trouble.
What do they say to their kids?
Yeah, yeah, exactly. Tip number 3. Patients with advanced CKD and end-stage renal disease have symptom burdens as high as patients with advanced cancer. This is surprising, but not surprising to me. I think of the people that I see routinely. I think of those cancer patients who often have just this tremendous symptom burden. But then when you see patients with CKD, especially end-stage renal disease, and reflect more on that, goodness, they do have a lot of quality of life changing symptoms. So more than a third, and again, this is starting at stage 3 of chronic kidney disease, will experience some or all of especially dry skin, dry mouth, sadness, sleep disturbance, irritability, sexual dysfunction, and cramping. The other symptom to be particularly mindful of is depression. So there's a substantially higher prevalence of depression in chronic kidney disease compared to other comorbid conditions. And I thought that this was just really fascinating. So if you take two groups of people, one with chronic kidney disease without depression, and the other group of people with just chronic kidney disease and depression, those with depression are going to have decreased markers of quality of life. And then they're also going to have an increased likelihood of progression to end-stage renal disease compared to their counterparts, increased rates of hospitalization, and the numbers don't lie, all-cause mortality at increased rates. So looking out for and managing those mood disorders, especially depression in our patients with chronic kidney disease, really can be life prolonging. And then evidence shows that symptom management is a top priority for patients with chronic kidney disease, and nephrologists tend to underestimate that symptom prevalence. I'm a visual person, so this is just comparing some of those IADLs or ADLs in those with chronic kidney disease and those without chronic kidney disease. And you can see for things like doing errands alone, significantly more difficult for folks with chronic kidney disease, and even walking. So thinking back to what are those symptoms, some of that brain fog and fatigue in particular, and how might that be affecting just their day-to-day functioning. We'll talk about a couple of those symptoms specifically and some of the evidence as far as managing or treating those. So with the pruritus, it's important to remember that it's a metabolic source, not an allergic source or another physical derangement. That dry skin might and likely will exacerbate the itching sensation. So just starting with your basic moisturizers and emollients is important. I usually tell people find something that's in a jar, not a squeeze tube. That's going to serve you better. It's going to be less irritating, has less alcohol in it, and so it'll work better. That kind of soak and seal method. So you get out of the bath or shower, and then you put that moisturizer on, and it seals in The moisture. Oatmeal baths have also been shown to be helpful for those with kidney disease and itching. Trying a cooling agent can also be helpful. That's where your topical products with lidocaine, calamine, or menthol in them, or even just a cold washcloth can be helpful. I always forget about this one, but your Zofran or ondansetron can also be helpful. And then 3 specific antidepressants have been studied and shown to be helpful, although I couldn't see any uh, proof, if you will, as to specific dosing, but worth trying and probably titrating if needed. Sertraline, amitriptyline, and doxepin. I know I've personally seen that amitriptyline and doxepin have been helpful. I haven't had good results from sertraline, but that's not to say don't try it. And then I've also had in these patients benefit from gabapentin, even though the evidence was a little less clear for chronic kidney disease and pruritus. I think it's worth a try if you need to. Not exactly sure as to why pain tends to be worse in chronic kidney disease. Maybe like we've said, kind of a broken record, just part of aging, but definitely higher pain symptoms in those with kidney disease. So we'll have to be mindful of both opioids and anti-inflammatory agents that we're using. We don't want to worsen their kidney disease, so I like to try something topical. Specifically, there have been studies looking at topical morphine in chronic kidney disease, and this specific concentration of gels. So if you're calling a compounding pharmacy, you can ask them for morphine 10 milligrams and 8 grams of sterile gel, and they can use it up to 3 times a day without harm and likely some benefit. Of course, Tylenol is safe and beneficial in kidney disease, and opioids really are safest options for those who aren't opioid naive and maybe with the methadone are at a low dose. Methadone, fentanyl, and buprenorphine have been shown to be the safest. And then if you are looking for a short acting agent, hydromorphone is commonly what's used for an immediate release. And the metabolite has potential for a neuroexcitatory effect. So just be mindful of that. And then also ketamine is also a good option. Fatigue, of course, chronic kidney disease can lead to fatigue, but also those comorbid conditions and other contributors. So depression, anemia, blood transfusions have been shown to improve fatigue, and patients who have received them self-report an improved sense of well-being. EPO stimulating agents improve fatigue and quality of life as well. Think about nutritional factors, sleep disorders, volume imbalance, and I generally am a fan of psychostimulants, but in chronic kidney disease, there's been no supporting evidence to use them for fatigue and may in fact run the risk of suppressing appetite. And then, of course, have those negative cardiovascular effects potentially.
Did they say why it's not supporting evidence? Was it negative evidence, like we're not getting good results, or was it just too few studies, like too little evidence?
There was good studies to support it, or that they looked at, but they did not show any benefit. So kind of interesting, because you would think anybody on a stimulant would feel better, but actually not in chronic kidney disease. Yeah. Right here, where's our coffee?
Yeah.
Important to look at fluid overload status. The goal is to manage those symptoms associated with being fluid overloaded, including dyspnea, the cramping from maybe swinging more towards running dry, and then debility. So I'd leave this more up to my nephrologist colleagues, minimizing the electrolyte abnormalities. But I can't help but go back to pathophys sometimes. And so looking at, okay, if I have somebody in the palliative care office who maybe I am managing this a little bit, they're missing their nephrology appointments, or compared to somebody more commonly for me in the hospice world who's experiencing fluid overload, what should my choices be? So the article that I was looking at with these tips said if somebody's got a shorter life expectancy, like on hospice, go ahead, use the loop diuretic, use that furosemide. It's going to be most effective for them or stand the best chance at removing some fluid. And don't be afraid to be aggressive because we're not worried about what the lab work might look like. We're not worried about a decrease in the GFR. We're trying to keep them comfortable versus somebody who is maybe being seen for palliative care and continuing with other medical interventions. Then that thiazide like metolazone plus or minus aldosterone antagonist like spironolactone is a good combination. And less lab monitoring required for that. So less to put on their plate because they probably already have enough on their plate. And then this idea of those more urgent situations, you've got somebody maybe on GIP status, so you have a few more resources wherever they might be. You can think about using sub-Q or IV furosemide, the onset of benefits within 30 minutes, so pretty quick. You dose those equally, whether it's IV or sub-Q. And then if you're converting from the oral dose, you want to divide the oral dose by half. And then just remember, I think you all will, but if somebody's got advanced kidney disease end stage, you're really going to have to push those doses. Yeah, you're going to want to get every last squeeze out of those kidneys that you can if that's what you're trying to do. So don't be afraid to use 80, 160 milligrams of IV furosemide to get them comfortable. And a few other things to think about when you're looking at the med list and they say, ugh, I just would like to lighten my load. I've got this pill burden. Is there anything we can do, especially in the hospice world? Be mindful that ACE and ARBs, looking at those, so the hypotension potentially contributes to falls and dizziness. And I talk about this a lot with patients in regards to blood pressure, but also blood sugar. Tight control of that is a long-term benefit. So it's pretty rare. Your blood pressure would have to be pretty high to experience symptoms or side effects from that. So I would rather err on the side of a little high or even a moderate amount high than risk running low. And those ACE and ARBs also run the risk of hyperkalemia, which we know can be dangerous too. And then other things when you're talking about quality of life and burden of appointments and potential harms, those bone density infusions and injections and things are always worth just having a conversation about to benefit versus risk. Tip number 4. Not quite halfway there yet. Differentiating between chronic kidney disease and acute kidney injury is important. In the elderly, CKD often progresses slowly, while acute kidney injury is a bad prognostic marker for all patients, regardless of age. So think of this especially in your inpatient palliative care consults. Other side. When you're having those conversations about what what the potential outcomes might be or what to expect. Acute kidney injury is comes with a much different prognostic marker than CKD. They both increase your mortality, but definitely different trajectories. So we'll look at that.
Yeah.
So the clinical course for chronic kidney disease, especially in the elderly, has been incompletely described by large studies, which is fascinating because my very first slide showed a tremendous amount of CKD in our population. So it sounds like there's a research potential here. Next year's AHPM maybe, right, guys? The outcomes, so progression to end-stage renal disease and death, can be influenced, though we know, by varied ages and comorbidities of the participants. Advanced stages of CKD are associated with higher risk of progression to end-stage renal disease across all age group. In older patients, the risk of death from non-renal causes increases with advancing age, right? So elderly patients with CKD tend to have a slower decline in GFR compared to younger patients. So thinking about what's the cause of that kidney disease, right? And our older patients aging, it's kind of normal. It's going to be that slower decline versus somebody who is much younger and has onset of new kidney disease. It's probably a different etiology. Estimating trajectory for elderly patients with chronic kidney disease requires weighing the overall risk of death from any cause against likelihood of renal disease progression. A pretty big study done with the VA in patients 85 and older, which is an impressive group. The risk of all-cause mortality eclipsed the risk of progression to end-stage renal disease, regardless of their GFR. So that just shows the point or proves the point that that slow progression of kidney disease is going to be slow regardless of how old you are in those older years. Versus a study looking at patients, or that same study, 65 to 84 years old with a GFR less than 15, then the risk of progression of end-stage renal disease outstrips the risk of death. So it's kind of like prostate cancer in my mind. The younger you are, the more likely something else is going to get you. Actually, it's the contrary, but it's similar. And then this is just, if you look at the picture, just showing us the impact that acute kidney injury has on prognosis. So something to keep in mind, again, when you're having those goals of care conversations, especially in the inpatient world. There's a couple different ways this could go, but most commonly it's down quickly. So whether they are in the setting of end-stage renal, chronic kidney disease, or no kidney disease, most commonly things move along pretty quickly after an acute kidney injury. It's always good to refresh on what is the prognostication, or how do we prognosticate an end-stage renal disease. Conservative management, meaning no dialysis interventions. You could have anywhere from a 6 to 23 month average life expectancy. And a big marker of that is urine production. So that's something important worth asking if they're still urinating. And then end-stage renal disease on dialysis, the life expectancy is still 5 to 10 years. So definitely a life prolonging intervention compared to the 6 to 23 months. And then I think this is something we've commonly hear, but the median life expectancy once someone discontinues dialysis is 7 days. Of course, that I I actually ended up discharging a patient from our hospice service who had been on for 2 years after stopping dialysis. Yes. So,
It's getting covered.
yeah, things happen. She would have really thrown that study off,
Yeah.
that data off. So, hospice eligibility is variable. So I think, oh, end stage renal disease, stage 4, definitely stage 5, they qualify for hospice. This article said, well, not necessarily. They really should have a GFR less than 15 plus at least one or more of uncontrolled metabolic derangements, uremic symptoms causing frailty or encephalopathy, a critical volume overload causing respiratory issues or nephrogenic ascites, calciphylaxis. And I thought of this, and there are not very many people who have a GFR less than 15 and don't have one of those. So I think it would be more rare to have somebody with a GFR under 15 who does not qualify. All right, wake us up a little bit again with another joke. A kidney stone walks into a bar. The bartender says, "What do you have?" And the kidney stone says, "No, thanks. I'm just passing through." Yeah. Tip number 5. Oh, perfect. We hit the halfway point at 8. Since patients with kidney disease have variable illness trajectories, shared decision-making and advanced care planning are essential to help patients decide whether dialysis or conservative management will help meet their goals. If I had a soapbox right now, I would get on it. I would love to have more palliative consults to assist with this. I think it's really, really important and doesn't happen enough. So chronic kidney disease, not just end-stage renal disease, are at risk for sudden functional loss or death due to those comorbid conditions we talked about. Even high-risk patients can see improvements with aggressive care. So this is challenging because it makes the individual prognostication more difficult and recommendations less firm. Nonetheless, it's still important to be having these conversations. Kind of takes us back to tip number 1, right? Many nephrology providers feel unprepared to discuss prognosis, end-of-life care, and non-dialysis management options with their patients. Very comfortable about what dialysis will look like and what the prognostication might be for that, but uncomfortable with the alternatives and offering those. Again, they cite the lack of training as part of that. A large percentage of patients with end-stage renal disease do not recall a conversation about alternatives to dialysis and also regret their decisions to start. Patients with kidney disease have a lower prevalence of advanced directives, which again is kind of mind-blowing. You think of, okay, yep, oncology patients, we often, I find that they've been talked to about advanced directives. It's not uncommon to have those already scanned in the chart by the time I see them. I would say most folks I see with end-stage renal disease don't have advanced directives. So the study reflects that as well. Lower prevalence of those compared to other patients with serious illness like dementia and cancer. Dialysis patients are more likely to be hospitalized and less likely to receive hospice care at the end of life compared to patients with cancer, despite having a similar symptom burden. All right, I've got a lot of, so you have to bear with me. I've got a lot of back to the basics, I think in this presentation, whether it be about statistics or pathophys, this I needed to refresh myself, and I think it's important we all know this if we are having the conversation with patients about dialysis and what that might look like. Or they say, oh, I've got an appointment coming up for AV graft. So we'll review those access options for hemodialysis. An AV fistula directly connects an artery to a vein. It's considered the safest access for hemodialysis, and it can last for years. It's the least likely to become infected or form a clot. It is best to have the procedure done 2 to 3 months prior to expected initiation of hemodialysis. So I will see this if in nephrology's note, if someone's approaching that dialysis time, they'll go ahead and get them set up with AV fistula. Compared to an AV graft, that uses graft material to connect an artery and vein, and it's considered the second best if we're ranking these. It's a little more prone to infection and thrombus, and the benefit to this, though, is it can be done 2 to 3 weeks prior to expected initiation. So if that timeline's moved in a little more quickly than we expected, but it's not quite emergent, this is a good second best. And then finally, a catheter placed directly into the vein. It can be done same day. It can be used for short-term use. A tunneled catheter is safer than a venous catheter, and that can be used for slightly longer periods of time. But this is maybe what you'll see more commonly in a hospital setting for a more urgent or surprise hemodialysis need that's temporary or expected to be temporary. And when having those conversations, there's a couple of contraindications to consider or discuss. So absolute contraindications, there aren't many, and no possible vascular access seems obvious. And then if they've got, it has to be pretty severe cardiovascular instability. That becomes the priority over hemodialysis. Relative contraindications, if they've got malignancy, except in the case of multiple myeloma, because dialysis is kind of a treatment option for that. Alzheimer's disease, advanced liver disease, and hypotension unresponsive to pressors. And indications for it, I said everyone else. All right, so if access isn't enough to consider, we have options for how are we going to dialyze. Peritoneal dialysis, there are actually several types of peritoneal dialysis. So continuous ambulatory peritoneal dialysis is manual and done several times a day. Continuous cyclic peritoneal dialysis is done automatically by a machine overnight. That's more commonly what I see. And then intermittent peritoneal dialysis is done at home or a healthcare facility like CAPD, but more intermittent. So often you'll hear patients being offered peritoneal dialysis overnight at home. Things to consider, and our nephrologist colleagues are really doing this for us, but just be familiar with what you might hear patients saying as to reasons why they are or are not a candidate for peritoneal dialysis. Because I think for a lot of the patients I talk to, they're excited about this potential. Contraindications, if they've had a number of abdominal surgeries, they've got a significant hernia present, they really need a lot of caregiver support in this. It's would be challenging for someone to manage this entirely on their own at home, or if they have a GI tract burden, like inflammatory bowel or an active diverticulitis infection, inflammation. It is much less effective or efficient, I guess I should say, than hemodialysis. It can cause hernias. It results in oftentimes a weight gain and hyperglycemia, and that's because the solution used includes dextrose. So they say it's like exposing or ingesting hundreds of extra calories per day. And then anytime you're injecting fluids, especially in the peritoneal cavity, you're at risk for infection. So peritonitis is not uncommon.
What is the peritoneal dialysis access? Like, is it just a peritoneal drain? You know, like you're talking about all the,
Yeah.
but I mean, is, you know, like we talk about fistulas and all the stuff for
Yes.
AV for regular
Yep.
hemodialysis, but is it literally just like a peritoneal, like
It's a cat. Yeah.
like
Yep.
the ones they do for
I think it's similar to what they do.
a paracentesis?
Yes.
Okay,
When you leave that.
meaning like it
Catheter
can
in.
be replaced or it can fall out. Like,
Yes.
more commonly than like.
Yes.
Okay.
Yep, exactly. It gets a little bit tricky when we're looking at drug clearances as well. And admittedly, this is a really dense slide, so let's just skip it. Yes.
That's the one, the ICU, like,
So,
let's just skip it.
alternatives to dialysis. So that's the conservative management that we talked about. And that is most works most well when there's that multidisciplinary approach with palliative care and nephrology. Multiple studies have shown it does not result in immediate death, which I hear often. People will say, oh, if I don't start dialysis, then that's a death sentence or that's a suicide. And it really is not. And there are variable outcomes like we talked about when thinking about prognostication.
It's 6 to 23 months.
Yeah.
Without it, like.
But then, 12 months isn't uncommon,
No.
kind of as your median there. And then delivery of care can be improved by more upstream integration of palliative care skills, right? So we know this, a clear discussion of the patient's values and preferences, more attention to advanced care planning, and increased primary palliative skills in collaboration with nephrology. All right, tip number 6, we'll keep moving. Dialysis initiation inconsistently modifies symptoms experienced by patients with kidney disease and may not always prolong survival. If I've heard this once, I've heard it a million times. People really expect that when they start dialysis, they're going to start feeling better. And they most often do not. And sometimes they even feel worse. So that frank conversation that this is intended to be a life prolonging intervention and not necessarily a quality of life improving intervention, I think is very important, and maybe not even really being said, or at least not clearly to patients. Dialysis does not impact symptoms related to frailty and aging, which I think is important to remember too, or think about. And although there are limited data, patients with other life-limiting illnesses may not have prolonged survival with dialysis. So that makes sense. There's some studies.
That's a good picture.
Yeah, I know, right? It's funny, bring it up. Yeah, when you're a nephrologist and mom tells you to cut the tomatoes, you will never slice a potato.
I'll never
Not
listen.
yeah.
Never thought about that, but now.
Yeah.
That's
It's
what that is.
perfect, right? Number 7, patients with end-stage renal disease have complex pathophysiologic mechanisms that can be thought of as the confluence of cardiovascular disease, chronic inflammation, and bone disease that collectively drive malnutrition and medical frailty. Whew, spoken like a nephrologist giving tips to a palliative care specialist. Frailty, as a reminder, is age or disease-associated loss of physiologic reserve. So I'll often look at somebody and say, oh, or they're described in their nursing notes as looking frail. What does that mean? It's that loss of physiologic reserve. We can characterize that by reduced strength, endurance, and poor physical function.
Let me see, this is your We Fit age. You ever do We Fit?
Yeah, yeah.
Give you a number.
Right.
85 and you're like,
Yes.
I'm 35, but I'm 85 by We
Yeah.
Fit. Like, that's what I think of frailty.
That's great. As kidney disease progresses, the prevalence of frailty increases, makes sense, right? Up to 30% of hemodialysis patients, I'm surprised it's not more, can be categorized as frail. This leads to increased hospitalizations, morbidity, mortality, and just that widely variable illness trajectory. Outside of kidney disease, you can look at predictors for frailty, including age, other comorbid conditions, and then chronic inflammation, which I think we're starting to, in general, hear more and more about the long-term results of chronic inflammation. So looking at the reversible factors, which this article is saying if you're frail, you can reverse some of that damage that's been done. Not all hope is lost. Looking at nutritional status, fluid status, metabolic derangements, and then, of course, preventing acute illness or treating it as soon as possible. And this is that infamous trajectory graph that we look at, and really just trying to show that that kidney disease follows that generally that chronic disease burden trajectory of the ups and downs and never quite getting back to your baseline. But when someone's progressed to stage 5 and not on dialysis, or chooses not to be on dialysis, it looks more like that cancer cliff. Tip 8, patients on hemodialysis have high mortality, and there are validated prognostic tools that can help predict mortality survival in end-stage renal disease population. So this is comes from a large data set from the US Renal Data System. General trends, there's an estimated annual mortality for patients on hemodialysis of 20%. The first year of hemodialysis is particularly high risk. So if somebody gets through that first year, then their odds improve, you could say. There's an early spike in the first 2 months in particular. Back to my MD Calc, if you're looking for a resource for this, the Charlson Comorbidity Index is the validated tool for this calculation. And then there's some other, I've played around a little bit with this one. This one was recommended by one of the kidney societies, QXMD. So that's worth looking at as well. Tip number 9, although indicated for multiple chronic conditions, the use of agents that inhibit the renin-angiotensin-aldosterone system need to be individualized for frail, elderly, and dying patients. So we talked about this a little bit earlier with pill burden, just taking into account the cardiovascular and renal benefits with not just these medications, but all medications, especially in our chronic kidney disease patients. The landmark studies show benefits did not include very frail patients with limited prognosis. Because of this mechanism of action, they predispose this patient population to worsening kidney function and hyperkalemia. All right, we're getting there. Tip 10, patients with end-stage renal disease underutilize hospice compared to those with other serious illness because hospice regulations make it difficult to utilize hospice services while continuing hemodialysis unless another distinct terminal diagnosis is present. So I think the general trend has been, and we talked about this with my hospice rules and reg lecture too, that the other distinct terminal diagnosis really is not excusing coverage for hemodialysis because it is a prognosis affecting intervention. So hospices really are starting to defer more anybody on hemodialysis, even if they have an other unrelated terminal diagnosis, if they wish to continue with hemodialysis. 46% of Medicare patients in 2015 utilized their hospice benefit, which I said this before. I think that's a surprisingly high number of Medicare patients utilizing hospice, but only 25% of Medicare beneficiaries with end-stage renal disease received hospice care at the time of death.
But the end-stage renal patients are using 125% of the Medicare dollars.
Correct.
Like,
Yeah, I think I have this.
You see, as hospices are making that trend, any sort of trend for the home-based palliative care or ambulatory palliative care to fill in that role and do a lot of that
Definitely.
almost concurrent
Yes.
care that hospice would have been doing.
Yes, exactly. Yeah, I think I know in our practice, I can only really speak for, but we're definitely having, in general, not just end-stage renal disease, but patients who are wishing to pursue IV fluid hydration or whatever it is. And so we're really serving as that bridge for hospice care and intervening more than maybe we would have otherwise, or previously, I should say. Compared to cancer and heart failure, the final month of life with end-stage renal disease includes more hospitalizations, more use of ICUs, higher rates of CPR and mechanical ventilation. Amy, yeah, this is Amy was pointing out. They're more likely to die in a hospital than out in the community. And so this is kind of what you were talking about. Medicare spends, and again, I'm surprised this isn't higher, but over 83,000 per year per hemodialysis dependent patient. I don't know.
have you been in a dialysis center ever?
I would think it'd be more money than that.
It's pretty lean the way they.
Yeah. So therefore hospices assume a huge financial risk in admitting patients with end-stage renal
2012?
disease.
Yeah, right.
Yeah.
I double it. Yeah.
Probably, gone up quite a bit since then. And I think too, that's just the dialysis cost, right? That's not the cost
Of
of all the other, complications, comorbid conditions, hospitalizations, et cetera. Okay. This is maybe what you really want to know.
Finally.
Yes. You've got somebody on dialysis. What do we need to do with dosing? In particular, anyone who's worked with me knows I love methadone. So you should know.
Any conflicts of interest?
I know. I'm not being paid, but
I know. It should be.
Yeah, right. This is part of the reason why I love methadone, right? Concentrations are not significantly altered in renal impairment. And there really is not adjustment in dosing that's needed. You do have to take into account some comorbidities, right? Look at their QT before starting and after, monitor that. And this is something that I still often forget. Sodium bicarb supplements, they alkalinize the urine, which can prolong methadone excretion. So that's the one thing that can affect methadone.
Do you have any way to clinically apply that? Meaning you're on this, so I reduce by.
Be aware.
Okay.
Yeah. No, there's no, I couldn't find any,
But even ballpark, reduced by 10% if you're on an alcohol.
I think that's just what it is with methadone in general. It's a ballpark, for dose adjustments too. So, just go with your gut.
Go with your gut.
Yeah.
Forget the MD calculus.
Yeah.
Sounds right.
So the other reason I love methadone in this population and in general, it's not significantly removed by hemodialysis. approximately 2 to 15% removal, and the pharmacy or pharmacologic world said that's really not significant. So you can, though, if you wanted to be cautious, if you're starting methadone, you would administer 50 to 70% of the usual indicated dose is the recommendation, which is funny, right? It says, oh, there's no significant, but yeah, why don't you go ahead and start it at a lower dose?
So their pain's just out of control, basically.
Yeah, practically, I don't reduce it if I'm starting somebody who's on hemodialysis on methadone. Titrate gradually, which is what we do regardless. And then you don't need to supplement post-dialysis because you have that really limited removal by dialysis. And the same is true for peritoneal dialysis.
The dose.
Yeah. They say it's not significantly removed, even less than with hemodialysis, but you could still start at a 50 to 75% reduction.
Nice.
You made it.
826.
You made it. Thoughts, questions? Are you still awake?
I had two questions. We talked about somewhat on inpatient about like, and maybe it was here at Trillium too, about oxycodone in
Yeah,
like it's kind of the, you mentioned hydromorphone as
Yeah.
protecting and sure, but also it seems like oxycodone has been shown to be pretty well tolerated in
Yeah.
the renally impaired patient.
yeah. So the nephrologist, this main study, their recommendation or article that I reviewed,
Yeah.
their recommendation was the hydromorphone.
Yeah.
But I will say in practicality and just the reviews that I've done, there's no evidence to show that oxycodone is more harmful, I guess. But the big no-no is obviously morphine.
Yeah,
So
but it seems like oxy was
Yeah.
like a, now the kind of they go to.
Yeah,
Feel that way?
I've seen it used maybe like dosing it every 6 hours or every 4
Oh, sure.
hours, maybe.
Yeah.
Yeah.
And then I just was noticing with those curves, you know, we have those about the desensitization or the boiling frogs of people with like dementia or chronic illness or cancer and sort of like comparing, you know, a lot of families feel like, but they were doing so much better than like 30 days ago. But then you're like, go back a year
yeah,
and where are we? And it's really like this, but you know, it's more like this. So people are like, well, they're better than they were like since they, you know, the admission helps, but the whole downward spiral. So I don't think people pick up on that with end stage renal with on dialysis.
Yeah.
Like
I love the frog in the.
I use the boiling frog. I feel like I should have like a.
Yeah,
t-shirt
you're right.
or a pin
Yep.
because it's the only way I can, but it applies to so many things. So, but it just made me think of that one. Yes, you showed those curves or those graphs.
Yep. And I think too, this is a little bit different than that, but I think it's funny you ask the family members and they'll say, oh, yeah, there's not significant change, but then you ask the person how they've been feeling and they're like, I'm feeling crummier and crummier as the years go on. So
Yeah, they're
they
like,
might have a
easier
different.
to take care of.
Yes.
Cause they're more tired. Yep. And then my always like ER statement is you mentioned the IV Lasix. I more notice it, I mean, those high doses are totally true. But what I find is that people forget that when you're fluid overloaded, your GI absorption, I always say your GI tract is just as fluid overloaded as your legs. So the absorption of oral, even if you don't think they're at crisis, you have to remember that like when these people will come in the ER and they're like, I'm taking my Lasix or I'm taking extra or whatever, is they're not absorbing any of it.
Yeah.
So as soon as like people are in kind of a fluid overload state, assuming it's appropriate that they're like in a healthcare setting, that often moving to IV parenteral diuretics earlier at lower doses will be more effective than trying to like either increase their oral or waiting until they're so fluid overload. But you just have to remember the gut is no different than the rest of their body.
Yes.
So
Yes.
Every
I've-
12.
yeah,
Yeah.
like edema is edema. So I've seen that a lot over the years.
That's a great point.
And then also about access, we had a patient at Metro and I've had several when I did my vascular wound care stuff. Subclavian steel. It's just something when we talked about complications, like it's not something I ever knew about before I did wound care actually. And then we had a patient, a young guy at Metro. And when you have a fistula in that extremity, you can get subclavian steel. And this guy had like intractable hand pain and was seen by like multiple specialists. And in the end, he even had some gangrene, you know, of things. But the only option is to basically tie off the fistula, surgically. And this kid wanted his like fingers amputated because they were so painful. But I have seen people where subclavian steel gets missed because they get like worked up for other things or like neuropathy. And if it's on the same side as the access point, you have to recognize that sometimes that can be an issue and they get ischemia of the extremity. And it's more chronic. It's not like, there's a few
Yes.
cases, but this
Yes.
is, that's like,
Chronic buildup, just like.
No, we have somebody in right now on our service who has gangrene of the digits, yes, and is hemodialysis.
is he getting it?
So-
Okay, so he buys, so there's a special, just so you know, there's an
Yeah.
order, there's an ultrasound order, vascular Doppler ultrasound that you can order, that the vascular surgeons order, and I forget what it's called in like Epic, but it specifically looks for subclavian steel and it's something to do with like the velocities. It's over my head as far as what they look at. But
Yeah.
it's really important, or they can get a CT angio of the extremity because it's fixable. Assuming you have another site, this kid that we didn't actually have another place he could go weirdly, he was so long-term, but like, if it is just on that extremity, the only way you're gonna fix that is taking care of that.
So keep in mind.
And then Gretchen just threw that link into chat for that other calculator.
Oh,
The
great.
6-month mortality on HD calculator, which was created by the QXMD.
Perfect.
Yeah.
Thank you.
Yeah, you can go ahead and stop share.
Okay. Yeah.
And why is creatinine clearance not recommended by the American?
Yeah.
I was like,
I think we.
because literally we live and die on that stuff.
Yeah.
And like, that's how all the pharmacists prescribe everything is by creatinine clearance. Like Neurontin dosing and stuff. I just
Up there.
thought that was weird,
It is weird.
unless it's outdated, like,
I don't think it is.
okay.
I think it's everybody wants their own. Yeah.
Their own thing.
Yeah.
Like, we prefer our.
Yeah.
PFR is our thing.
All right, other thoughts or questions?
Erin, do you find in like regulation and hospice eligibility? I know a lot of people don't have a GFR of under 15. You look at the whole picture and
Yeah.
everything. If you do that, do you get a lot of blowback from auditors to say, hey, this guy really was a 20 or 30 GFR? There's a lot of people that, you'd have to be pretty bad to be 15. So
Yeah. Yeah. If I can, I will use a comorbid as my primary hospice diagnosis if I feel like I can't make a case just based on what their
even
kidney disease
though
stage is.
it's
Yeah.
good enough, but
Yeah.
I just thought it was a real strict diagnostic guideline, but
Yeah. But like we talked about, they're likely to have probably either,
they're probably.
heart failure or they've had strokes or they've, other significant things that I can.
I've yet to find someone with like end-stage renal disease and no other diagnoses.
Yeah.
Like,
Yeah.
Right.
unless it's like a like some weird pediatric.
I guess I'm thinking more of like the 3s and 4, well, not 3, but like 4.
Yep.
4 level.
Yep. And we know that even stage 3 or 4 affects mortality rate. So it's always, even if that's not why you're recommending hospice or they're not on hospice, it's important to include those in your narrative note.
Comorbidity things. Yeah. Okay, thank you. That's